Hello, peeps. Welcome back to the Fly Shit and Scholarship Podcast. I am your host. It's Dr. Meesh, also known as Dr. Tamisha Davis. Today with me, I have the lovely Dr. Tierra Hollaway, who has a PhD in marriage and family counseling from North Central University. I connected with Dr. Hollaway through one of my homegirls, and we've kind of been like chit-chatting ever since, and I am so happy to have you here. How are you?
Yes, I'm doing good. I'm doing good. How you
I,
doing?
I'm doing well. I can't complain. I absolutely love your sweatshirt. I'm so jealous
Thank you.
because I wanted one so bad but did not get a chance to like grab it, but
Yes.
I am so jealous. It looks so good on you.
Listen, we love to support some mental health, advocacy, all of the things.
1000%, 1000%. How have you been?
Honestly, I'm doing good. Life has been moving real fast. It's a lot of emotional roller coasters of things happening, a lot of changes happening for me in the near future. I may talk more about that. So yeah.
Yeah. So tell us more about the work that you do.
Yes. Hi, my name is Tierra Hollaway. I am from Jacksonville, Florida. So if you hear an accent, that's where it's coming from. Duval County, what's it? So I've been in New York for 8 years now. And I have a background in marriage and family therapy, specializing in medical family therapy. So what that means is I have a lot of experience in working with individuals and families of people that have someone with a chronic illness.
Mm.
So I have a lot of experience working in community settings such as nonprofits, um, and like outpatient clinics, but then also working in like healthcare settings, so like hospitals, um, outpatient substance abuse treatment centers, things like that. So I have a lot of experience in different areas,
Hmm.
focused on mental health as the base. But so I'm excited to talk with you all.
I love it. I love it. One of the reasons why we connected is because you were in academia at the time, and so we kind of connected on that front. But as soon as I thought about creating this platform and having this discussion about code switching, I thought of you, for so many reasons, right? Because of the experiences that you've had, and I will let you share your version of the story, right? Because I don't want to water it down. But I thought to myself, like, who better than to have this conversation with than Tierra, because
Yes.
of how code switching has come up for her and her experience and how it's really shaped your path and your career. So tell us more about that.
Like I said, a lot of my experience had been in like working in either like healthcare settings or like nonprofit, and I wanted to expand my knowledge and experience after I finished my doctorate. I had applied for a research position at New York University. I was doing that. I enjoyed it. The research was focused on the COVID-19 pandemic, and how Black and Hispanic individuals were hesitant about getting tested for COVID-19. Not even getting vaccinated, but just getting
Mm,
tested.
mm-hmm.
We spoke to people that came from different areas of New York City, where they lived in Brooklyn, the Bronx. We showed them like the data of like how the pandemic has been, having an impact on their community as far as like being hospitalized, being positive, all of the things, and just tried to really get more insight of people's hesitations about even just getting tested or what they thought about the pandemic. So while doing that, I still felt like there was more that I could be doing. So like
Mm.
I'm used to like being extremely busy. Like
Yeah, yeah.
I worked on my dissertation during the height of the pandemic and still was going to work at a hospital. So like I wasn't able to stay home. Like I think I was very much in like high gear.
Mm-hmm,
so
mm-hmm, mm-hmm.
and it took a long time for me to come down from that. But I was used to being very busy, and even doing the research position, like I feel like there was more that I could do. So I went ahead and applied to be an adjunct professor for the fall of 2022. And I taught a research class and a human development class. And that experience definitely it shook me. It shook
Yeah.
me up.
Yeah, yeah,
So, like with my line of work, I'm used to being very like authentic with people, working with families and people like in nonprofit world and even in healthcare. I show up as my full self. We have like real conversations. But I tell them like, hey, like in addition to me being your therapist, I, as a human being, I care about you. So like before we even start the sessions and I ask, hey, how you doing? How your mom and them doing? I really do mean like how everybody doing? Like because
mm-hmm.
also I'm from the South, so I got this different way that we start conversations and stuff. It's
Yeah,
like I don't want to just like start the conversation being all in your business like why you got an ACS case? So like, what's going on with this?
yeah,
No, like I want to like let's have some introductions first and things. So, but working in academia was a wild experience for me. I've never felt like I've had to code switch, and that was the one time that I felt that I needed to, or I was like pressed to have to do that. And I'm used to like PWI. So like I
mm-hmm.
went to PWI. I went to an all women's college, PWI. I went to grad school, PWI. So like I'm used to that, but it really had me like second guessing myself. The imposter syndrome all of a sudden really started like kicking in. The students, I think at first they were confused. They thought that I was a student, and then when they saw me walk to the front of the classroom, like they were just like, "What in the world?" So and then like it wasn't a lot of minorities in my classes. So, that's also another layer, right? Um, I had one black student, and I remember when she realized that I was the professor, she purposely sat right in front
Mm,
of the class. And she was
mm-hmm.
just like, oh, I'm so excited about this. And that whole experience just really like it confirmed some things that I already thought with my experience of working with people that came from like these privileged schools and their insight of working at like nonprofits in underserved communities and the way they thought about the cases that they had, the families that they worked with. And I was like, okay, now I see. I see why y'all are leaving school thinking that this is okay. Because
Yeah.
no. So I felt like everything is like a meme and a clip for me. But I felt like, not on my watch. Not on my watch. No, absolutely not. So we had like some real conversations, and I actually ended up, I stopped teaching one of the classes mid semester because it was a very toxic environment, and I was like, this is not. It won't do anyone well if I stayed for the remainder of this semester.
Mm,
I had a student feel very comfortable with like approaching me like it is your job to do this, this, and this. Like what? I felt like a SpongeBob meme. Like, first of all, I am your professor. Like, why do you feel so comfortable with approaching me like I am some girl off the street? So I
mm-hmm.
think there was like a lot of factors that like played a part in it. My age,
Mm-hmm.
how people perceive me just as like a black woman. I feel like in the beginning of the semester when I was very lax and like, just was trying to work with students, everything was fine. But then when I started being firm on like certain like boundaries and like what is expected of them, because you're in grad school. Like
Yeah.
this isn't undergrad, this is grad school.
Yeah, yeah,
And you're at
yeah.
NYU. So like I need everyone
Mm-hmm.
to use their brain cells. And once I started being firm on boundaries and expectations, they looked at me like, how dare you? And I remember reaching out to you like, girl, what is this? What is this?
Yeah.
And I even had conversations with like the directors, administrators of the whole experience, and they called it out, and they knew what it was because I called it out too. I said, "This is why she felt okay with talking to me this way." And they said, "Yeah, we agree with you, and you have done over and beyond what an adjunct professor is supposed to do." Okay, and y'all aren't going to do anything. So effective immediately, I'm leaving.
Mm. Mm.
And that is my way, that was my way of advocating for myself because
Yeah.
my mental health was on the fritz like that. I was so stressed out, and like my anxiety was through the roof, and like I was dreading each week, like it would be like the night before. Even though like I've prepared everything like from top to bottom, I would still be at home like questioning myself, feeling very anxious about the next day, not wanting to go, but like of course like I still went, and like crying after class, like
Mm.
all of the things. And then when I had other students approach me and say, "Dr. Hollaway, like they are only treating you like this because of this." I had other white students tell me that they talked to their therapist about it because it was bothering them.
Wow.
And I was like, okay, yeah, no, this isn't healthy.
Yeah.
So yeah. So after that, I was like, oh, okay, I got a blast. Like I like I thought I wanted to work in academia, but this is crazy. And then like even amongst like in addition to that, um at the time I was considering doing a postdoc at NYU, and I
Hmm.
was just like, no, I don't like I don't think so. I don't think like I didn't feel safe in that on that campus. It just didn't feel like a safe environment for me. And then just seeing the way like my director at the time for the research position, she just always looked stressed and
Mm.
like not really happy. And I was just like, I've worked too hard and I don't want to spend the rest of my career looking like that. Like, I don't, I was just like, no, I want to enjoy the work that I do. So I was just like, no, okay, well, I know I love working in healthcare. So I transitioned right on out into a role at a outpatient healthcare clinic. Helped them start a new program that was geared for their pediatric population,
Nice.
newborn to 5 years old, and helping connect the families to additional resources, helping connect the child to early intervention, things like that, like those things that are needed. So that is what I'm doing right now.
Yeah, I champion you so much because having the ability and the confidence in yourself to say, I've never had to code switch really in my life, and I'm not about to start now because I'm at these people's school and these universities.
Yeah.
And before, because on previous episodes, I've talked to other people about how much code switching can have a huge impact on your mental health, right, and your overall well being, because it's almost like this masked persona
Yes.
and personality that you have to maintain in order to operate in a system, right? And a big part of that really does weigh on you because you're
Mm-hmm.
battling like, I want to be my authentic self and I want to show up as myself because that's easier, right? It's easier to not have to overthink every step that you do, every decision that you make. But when you do, it weighs on you.
Yeah.
And it maximizes the feelings that you have about imposter syndrome because, in some ways, you are being an imposter, right? Because you're not
Yeah.
being yourself. And so, I truly do champion your ability to say, like, nah, like, I'm not about to do that. I'm out in the middle of the semester. Y'all figure it out. Because at the end of the day, they will, right?
Yeah.
Like, they will. And I love that you put yourself first in this situation and that you took a stand and that you set a boundary, because sometimes
Yeah.
setting boundaries can be really difficult. They can be
Yeah.
really nerve-wracking, but the fact that you did that for yourself is amazing, and I know very much
Thank you.
inspiring for other people.
Yeah, yeah. I was like, yeah, like yes, it's additional income, and of course, because not by no means am I balling, right? Like
Mhm.
we,
Mhm.
the cost of living is crazy in New York, like all
Yeah.
of the things, but at what cost? Like I need to be able to be a person and function, So I was just like, no, I got to put me first. I got to put me first. So
Yeah.
I had to do it. But I think there was also power in even being like, I won't even allow you to use me until the end of the semester. Like,
Mm.
no, effective immediately now. Like, we've been going back and forth for weeks. I've been telling you what's been going on with this, and y'all really are like, oh, we'll look into it, and oh, well, no, 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 no. Because then, you know, if someone was to snap, like, you don't know what a person's mental capacity is or what their state is. And
Yeah.
so if someone was to snap, then you would flip it and I would be removed immediately.
Mm-hmm.
But you're allowing a student to treat a professor like that.
Mm-hmm.
And I was like, this is multi-layered. And I was just like, I'm just not, I'm not, I
No,
couldn't.
it 1000% gives big boss shit. Like it really does. It really, really does. And the thing that you said is I work too hard, right? And I say this so much in my personal life. Anybody that knows me, like I love where I am right now. I love what I do. Simultaneously, though, I have never been the kind of person that would I'm going to start before I say this. I'm going to start by acknowledging that there is privilege in this, right? And I acknowledge my privilege and my ability to do so. But I've never been a place where I'm going to let a job stress me out, right?
No,
Because
same.
I've worked too hard, right? I went to school for I mean, what? God knows how many years, right? You do 12 years in high school, you do another 4 in undergrad, you do another 2 in your master's,
Yes.
another 4 on top of that, right? Like somebody do the math.
Yes,
But
yes.
and I might not be able to spit out what the numbers are in mathematical equations, but I can spit out what that means for me qualitatively, which is you not finna play with me.
Yeah, no, yeah, no, absolutely. Like, I really had to, like, I had to talk to like my dad, and like I spoke to like some of my friends, and like you said, like I have never been like, oh, I have to stay working here. Oh no, like I will leave. Like, I will figure it out. I will leave. Like, and I think the thing is, like, the bright side of someone that's been in school all this time, like, it's like, okay, like, no, I know how to just like exit a situation and pivot. Something will find me, something will come up, but like, I know I don't have to stay in this situation. So, yeah, no, I was like, nah,
100%.
you're not about
I
to play
will,
with me.
yeah, and and I understand that like that may mean that I have to do some work that I really don't want to do for a little while, but at least I know that I stood up for myself. At least I
Mhm.
know that set a boundary and protected myself, right? So you have pivoted, you set the boundary for yourself. You are working in a capacity right now with young babies and with children. But before that, or a lot of your research interests and your work has been related to mental health, stability for family units, and especially as it relates to substance use. So tell us a
Yeah.
little bit more about that.
Yeah, so when I was working at a one of the city hospitals in East Harlem, I was there for 4 years, and while was working there and um, seeing individuals who were admitted into the hospital due to something related to substance use, right? So while they were in the hospital, I would go in their room and just like talk with them, see if they're interested in any outpatient treatment once they're discharged, getting to know more about that. And then I had the privilege of being supervised by the like clinical director of like substance use treatment services at that hospital. Who was a black man, which I was so appreciative of because representation, right?
Mm-hmm. Mm-hmm.
And he just like guided me on like so many things. It was just like so like supportive and contributed so much to like my growth as a professional, and just like while completing my doctorate, so like the dissertation part, everything. And so I told him I wanted to really like learn about the field of substance use and like addiction, and like learning about the medications, learning about like all of the things. And so like he would just give me like articles to read. He would like, hey, you want to check out this book? You might want to, find something in there that might pique your interest. So then he gave me the opportunity of conducting groups. So
Mm.
I was able to conduct a group in like the detox unit. Then I was like, I really like this. And then I was able to sit in on some other groups that they had, like in the outpatient clinic in the
Mm-hmm.
downstairs area. And I was able to see how the patients that were on the out, not inpatient, were able to still come and go to these groups and really share their experiences and just be in community and encourage each other and just have like the real conversations. Like it's not no, oh, we gonna tread light and only say certain things. They'll be in there cussing and like fuck that shit. Like all and I was just like, oh, okay, like y'all are keeping it real. And then like mind you, we
Yeah.
in East Harlem too. So like they
Right,
was keeping
right.
it real, real. So I
Mm-hmm.
was just like,
Mm-hmm.
okay, I like this, you know. So I asked my supervisor if I could join the team in the outpatient clinic to help them because of course they were like understaffed. And so I was able to have like a small caseload, and I am always like so grateful for that experience because it just really like opened my eyes to like the field of like treatment services for this population that a lot of the times is like so heavily like stigmatized, and people often turn the blind eye to them, and just have all these judgments without really knowing like their story, right?
Yeah.
And so it was a huge shift at first when I first got my first few clients, because you're dealing with people from all like age groups, right? I've had people that were like younger than me. I've had people that could have been like my grandparents.
Mm.
And I think with anything, if people are used to operating a certain way, even when it comes to like receiving their treatment, like they're not used to having to actually sit down for like a weekly therapy session. They're just like, oh, I just pop my head in, say hey, and then I go down the hall, get my medicine, and I leave. And I
Yeah.
was like, no, 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 no. I was like, so I know all the counselors do things differently, but me, I really gonna get, to know you all. So I was like, I'm about to be on y'all like white on rice.
Mm-hmm.
I want to know. And some people try to be intimidating and say, give me my stuff now. And And I was like, we just gonna be sitting here looking at each other. Like, no. And then like, having to review like their toxicology reports like week by week, like seeing like, oh, you're telling me that you haven't been using, but then why does it say positive cocaine, positive amphetamine, positive amphetamine? What is that? Like, I need everybody to be for real. Do you
Yeah.
know that after you get your medicine, you are not supposed to be lingering around the hospital? Why, when I step out for lunch, I see you on the corner? What you
Mm.
doing? So once they realize that, okay, yes, Miss Holloway not playing, and then I started calling family meetings for some of my patients that I felt like needed additional support once you
Mm.
leave the hospital. So like, I would tell them like, okay, I can only go by what I see here. I said, but you need extra support when you're at home. So I had this one older lady. She used to give me the runaround so bad, and I would be on her like, okay, if you're supposed to be at the clinic at 1, why are you strolling up in here at 4? I'll be standing right in the hallway. Hello, come holler at me real quick before you get your medicine. Come holler at me real quick.
Mm-hmm.
So I told her, I'm calling a family meeting. I'm calling your husband, and I'm inviting him here, and we're going to have a conversation.
Yeah.
And she was upset about it at first, but then when her husband came, it was such a touching meeting. Like, her husband was in there bawling his eyes out, like, we've been married for 40 years. I want my old wife back. And like
Mm.
her story of even how she even got, addicted to substances was because of a surgery.
Mm.
And she got addicted to the pain meds, and then it spirals into you wanting to use other things. But just to like hear how her experience had like just like transformed like her relationship with her family, I was like, I want to do more research on this.
Yeah. Yeah. Yeah.
And
Yeah.
that's what led me to my dissertation. So I decided to do a research called Love During Recovery, which
Mm.
basically focused on people who were currently receiving outpatient substance use treatment and how they felt that their recovery impacted their romantic relationship.
Wow.
Like basically really focusing on the communication and the trust of the relationship.
Mm.
And I was able to hear like some heartwarming stories. Like some people, their partners didn't know that, this person was in recovery for substance use.
Wow.
Other people, once they found out, it's just like, oh, I can't trust you. Like, where have you
Mm.
been? How you know this person? How you know this person? Like all of the things. So, I just love it. I love it so much.
Yeah, so many, first of all, so thankful for the work that you do, right? Like I myself am a practitioner, but there's a special kind of place for people who have the energy, the bandwidth, and the passion to work in substance use and hospitals, right? And so
Yeah,
I want to
yeah.
start by first saying thank you so, so much for the work that you do and having the passion for that population, right? There's a couple of things that you touched on, which is the importance of family relationships during this time. um, I have been fortunate enough to tour a few substance use facilities, inpatient substance use facilities, some outpatient ones as well. And one of the things that they consistently stress. Now let me back up. I will preface with saying two of the ones that I visited were in Malibu, California.
Okay.
Um, One of them was at this place called Newport Academy, and it's for younger adults. And um, the last one I visited is in New Jersey. All four of them, I guess that was, did not take insurance, were private pay, which is another resource hurdle and issue. Because what I've seen or what I notice is that oftentimes the facilities that are private pay, they're able to do a lot more with their interventions because people are
Mm-hmm.
paying out of pocket.
Right.
But while there were stark differences in their population of interest, population of focus, their structures, one of the things that remained constant, a consistent constant, was the aspect of how important family relationships are in assisting people in maintaining sobriety and
Mm-hmm.
working through their substance use disorders. And
Mm-hmm.
so this discussion that you're having is evident not only in your dissertation and research, but across the board in the models that we use to treat substance use disorders. And the crazy part about it, not crazy but interesting, is when thinking about this population, right, and all of the things that come with substance use disorders, a lot of the times the family relationships are breaking down, right,
Yeah.
as a result of their substance use disorders.
Yeah.
And to share a little bit about my own personal background, right? Like I come from, I'm from a city, an urban city, right in DC, and so my biological father has struggled his entire life, and addiction, not a substance use disorders, right? That's a language piece. Substance use disorders has had a major like ride on my paternal side of the family, and it dismantles relationships, right?
Mm-hmm.
Like so much
Mm-hmm.
so where, it breaks down the barrier, it breaks down communication,
Yeah.
it breaks down support, and much of that is a result of the person who is experiencing the substance use disorders, just because of it how they respond to
Right.
their disorder. But what do you say to that, right? Like to the fact that the family unit and maintaining the family relationships are so important to recovery, but it's so difficult for the family members to be able to maintain their relationships because of how the substance use disorder impacts them.
Yeah. Yeah. So a lot of the times when I speak to people who have a loved one who is struggling with substance use, um, I tell them, I really like share with them like addiction is a illness.
Mm-hmm.
That's baseline, right? So, with all illnesses, there are certain treatments that you have to go by. Because, there would be like family members gotta be like, well, why she has to come here every day for some medicine? And the medicine make her drowsy. And this is another drug. And I'm just like, hold on. So, like, baseline addiction is a disease, it's an illness, right? So the same way somebody has diabetes, would you tell them you only take that insulin because you have some side effects? Would you tell them that? And they're like, well, no, because I got diabetes and I need my. I said, so exactly. So once you shift people, once you give them more knowledge, and it helps shift the way that they look at it, um, then they're more open and willing to kind of see, okay, how can I support this person?
Yeah.
I think a lot of times when people think about addiction, they're just like, mm-mm, like they chose to do this, they chose to do this, and you know they're not looking at it from like a health stance and like, no, this is an illness. They can't just stop. They need support. There's like levels to recovering from it, right?
Yeah.
And it's not going to always be linear, right? It's going to be up and down. So I think starting with like the psychoeducation of it all, I think that
Mm.
really helps people. And then it helps them to be able to establish like their boundaries of what they're willing to do. Okay, if I start to see certain behaviors, I can't handle being a part of it anymore because it's
Mm-hmm.
triggering for me.
Yeah.
So, yeah, I think that's just like how I've gone about it when working with those families and individuals.
Yeah, yeah. It's a tough ride for sure. It's a tough ride for sure. Because in the world of mental health, right? In the world of disabilities and disorders, we are more empathetic to things that we can see, right?
Mm-hmm.
So if I can see your disability, if I can see your disorder, like visibly with my eyes, I am able to connect with it a little more, right? It brings out a
Right.
certain level of empathy for me because I can see it. It is the disabilities and the disorders that cannot be seen to the naked eye that people have a difficult time with, and that the
Exactly.
stigma is created around, right? Because I can't there's nothing I can hold on to or nothing I can connect to, which makes it very difficult for me to provide empathy for you, right?
Mm-hmm.
Like I said, I can't trust it enough. Like it is a tough ride, right? It's a tough thing to manage because you have to build up the empathy to be able to understand that this is a person who is struggling with a real life disability, right? um but then also trying to figure out, like, well, then how do I maintain my boundary so that I am not impacted by their disability, but still find a way to support them emotionally and support them, as it is a crucial part. And it's like you said, and it's never linear, right? And I mean,
Yeah.
I try not to say always and never, but very, very rarely is this a linear process, right?
Yeah.
I mean, the one of the things that they tell you when dealing with substance use addictions is that it's not like I was an addict, right? Or I did have a disability, right? Like, no, I still have it. It's
Yeah.
and you gave the perfect example even with diabetes, right? Do we know people who have diabetes and don't need to take medication anymore? 100%, right? But these are not people who are saying I no longer have diabetes, right?
Right.
Like, it is something that you have to consistently be attached, not attached to, but it's a part of your identity, right? Like,
Yeah.
and I
Yeah.
do a lot of disability forward information or language, right? Like, it is a part of your identity, and so as a result of that, it really does look like a roller coaster. And
Mm-hmm.
so maintaining those family relationships is difficult, is
Yeah.
difficult. Yeah.
Yeah. Yeah, it is. Yeah. I think um so like even like with the okay, like how a person who is trying to support a family member who is struggling with recovery and how they try to maintain like their boundaries for themselves. I think one thing that you really can do is like hold someone accountable. Holding someone accountable may not always look like, okay, a hug, but it's going to be like, you said you're going to go to at least one or two groups a week. Have you gone to a group today?
Yeah.
Do you need a ride? Like that's a way to hold someone accountable. And it doesn't always feel good, but you're also like you're maintaining your boundary and you're showing that, hey, I care about you and I'm
Yeah.
invested in your recovery.
Yeah.
So I think that's like a step that can be done.
Makes perfect sense. Makes sense. You have, you're in New York, right? But you have, a decent history kind of like in this practice area. What have you seen, or how can you tell us a little bit more about how this disability category impacts people of color? And have you seen that it impacts them more than it might impact other people?
Oh yeah, absolutely. So like even when like working in like the hospital with this population, like you were saying, the centers that you saw that you went to in California, they're paying out of pocket. I was working with people who were on Medicaid, or some people who aren't don't have anything, right? So,
Mm-hmm.
but because I worked in a city hospital, you know, they have things that just connect people to the resources and the treatment that they need, regardless of all of that. But then when you enter a situation where it's like, okay, you need a higher level of care, you need a like inpatient treatment, residential treatment before you're ready for outpatient treatment because maybe you can't handle just coming here and going to a group once or twice a week and coming to get your medicine and going home. Home is too triggering. Like there's too many things
Mm,
you can't handle being by yourself. So you
yeah.
need all hands on deck, and that's fine. But then it makes it a little more difficult to like find treatment centers, residential treatment centers that actually accepts a person's insurance,
Mm,
and actually what does that treatment look like, or how long can they stay because they're not paying out of pocket because they have Medicaid. So those things, those are the barriers that come into play.
yeah. And, it goes back to the stigma that we have and the perceptions that we have about people, right? And their abilities to like pick themselves up by their bootstraps and like keep it going. And, a big part of the problem with substance use disorders and specifically how it shows up in communities of color is the public resources and the federal
Yeah,
and state resources that are not there to support them, right? I mean, we could talk all day about the war on drugs many years ago and what that looked like compared to how they're treating the opioid addiction crisis, right? Like
absolutely.
it is a parallel issue that and when I say they, I mean by the federal government, a parallel issue that the federal government and even state governments are treating very differently because of who the face of these things were, right?
Absolutely.
So in the 80s, right, and the 90s, the face of that was black people, right, brown people. And so because of that, we were incarcerating. Because of that, we weren't thinking about this much as a disability and a disorder. And even though that was years ago, we're still on the heels of it because it is still very difficult for people to get the services that they need. And you're
Yeah.
talking about medicines and therapy. It is not just like, AA is amazing, right? But AA and NA and all of those things, those are the therapeutic approaches, right? That kind of like help people shift their minds about how they manage their addictions and their disabilities. But there is another deeper side of this where people need medical support. People need
Yes.
more intensive care and interventions. But now we have the opioid crisis and we're pouring federal dollars into this, right? And state dollars into all of these initiatives because of who the face of it is, right? And it's
Mm-hmm.
white people, white college students, white younger individuals. And now
Now it's a
we want
crisis.
to now it's a crisis. Now it's a crisis, right? And so our people in our communities, unfortunately, are suffering, right? In the resource perspective, you mentioned that another part of the issue is the stigma and the stigma that's surrounding addictions. And you said one of the things that happens is because people don't understand why people end up where they end up, right?
Mm-hmm.
Can you give us some thoughts or some, I guess, answers to that for other people who may not know how people end up where they are and struggling with substance
Yeah.
use addictions?
Yeah. So, like, a lot of what I had noticed was one, there's something called like an addictive personality, right?
Yeah.
If somebody has like an addictive personality, like addiction may run, in their DNA.
Yep.
Like you mentioned, same for me. So like on both sides. So like I was very knowledgeable about addiction from a young age, and then like my parents were very intentional about talking to me about it, before I went away to college, because they wanted to make it very clear, like, okay, like, we just want to let you know, like, you've heard a few stories growing up, from both sides, but you really about to see when you go to like these college parties and things like that, how easy it is for, you're with your friends, they're having X amount of drinks, and you're going to see how they respond, versus you might have a different, reaction, just
Mm,
because of like a high threshold, right?
mm,
So I think that that's baseline. I think that people don't think about addiction from like the biological standpoint. And so if I am somebody that has an addictive like DNA makeup, um if I have to have a serious surgery and they want to give me these heavy drugs to help with my recovery process, my body may respond differently as opposed to someone who doesn't have that DNA makeup, and they're able to handle just, taking these strong pills, and then after they're done, they're done.
mm-hmm, mm-hmm.
I've had multiple patients that, they were receiving treatment for a leg injury, a back injury, whatever the case may be. And once they took that medicine and then they ran out and their refills ran out, they was like, oh, I had to find it from somewhere. So then, you go out on the street, people, street pharmacists, you got, oh, let me try this, and let me try this, and okay, I'll try this. And but the thing about it is, I explained to them, just because you bought something from somebody and they said this is the pill that I'm giving you, you don't know what that is.
Mm-hmm.
That didn't come from CVS.
Mm-hmm. Mm-hmm. Mm-hmm.
And on top of that, with fentanyl being a thing, you don't know what it's laced with. So I tell them every time, when you buy something off the street, if you're not getting it from your local pharmacy, you're not getting it from this hospital, you are playing Russian roulette with your life.
I want to add to that, right? You talked about addictive genes. You talked about how that shows up in people having surgeries. I'm going to add to that, right? Along with addictive genes, substance disorders and disabilities can be a learned behavior, right? A learned behavior, a coping mechanism, right? That people
Absolutely.
use in order to survive.
Yep.
And if we are centraling this conversation on our community, then we have to consider the fact that we're talking about a population of people who are living in scenarios, in high stress scenarios, high trauma filled scenarios, right? And researchers have already told us that Black and brown people suffer from PTSD simply
Absolutely.
because of segregation, simply because of racism and discrimination, simply because of poverty in
Mm-hmm.
itself, right?
Mm-hmm.
And so I think the psychoeducation piece and understanding that it's not just about somebody wanting to be frivolous and pick up a substance and try something and oh, now they're addicted and all of this was choice. There's so many layers that are packed within it.
Yes. They're
And
trying to survive.
yes, yes, people are trying to survive. And you know, it's starting to the drugs of choice are shifting a bit, but shifting to things that are just like not like also just not good for you, right?
Yeah.
Like you talked about the cocaine, right? And what that means and how people are getting pills off the street. Well, over I think it was in 2020, maybe they did a research study looking at overdose rates and they basically noticed that for cocaine related overdoses, right, which many people don't recognize that is a thing, for cocaine
Mm-hmm.
related overdoses, they tripled, right? For methamphetamine related overdoses, they quadrupled,
Yep.
right? In the span of like 5 to 10 years. And
Yes.
it's not that, like, it's not about usage. It's about exactly what you said about if I am now addicted to something or I am now struggling, right, with my usage of something and I need to access it more, I can't go to the pharmacy to get it, right? I'm going to
Right.
go to my neighborhood pharmacist to get it, which is now these things are being cut with other things. And the overdose rates for these particular things are rising because of the things that they're cut with.
Yes.
And it's significantly impacting us more than our white peers, and that is because of a resource issue again, right? If
Exactly.
we can't afford to buy clean drugs, you know? And so, because I can't afford to buy clean drugs, I am typically going to be the one that's impacted by the cut drugs, right? And what we
Right.
mean by cut drugs is like someone takes the purest form of something and they cut it down with additional substances to stretch it, right? To make more dollars, to make more money. That is the difference in between cocaine and crack, right? They are the
Right.
same substances at their core. Crack is just what they used or what they had available to them in black communities and poor communities, because we took cocaine, we wanted to sell it, right, but we needed to stretch it to make more
Right.
money, so we dilute it with all of these things, and it's a harsher drug. So when we see numbers like this, it's not even the resources that's the problem, right? It's also the way in which drugs are pandered, or the way in which drugs are distributed in poor communities. It's 10 times more harmful.
Yeah. It's horrible. It's really bad. I had a patient and he wanted to, decrease his use. But then he worked in a trap house.
Mm.
And I was like, okay, I need you break this down to me like I'm 5 years old. Okay. I need for you to really break this down to me.
Yeah.
Because every week we was going through his toxicology and I'm like, okay, positive cocaine, positive cocaine. Oh, and it's positive for this too. And this too. Well, I don't know where that came from. You're in a trap house, sir. You are in there cutting up, doing all this stuff. Then you're telling me how some of your counterparts are passing out while in the trap house doing what y'all doing. Somebody dropped dead one night. One time, somebody dropped dead, and I remember meeting with him, and he was so sad. And I said, "You see," I said,
Mm-hmm.
that's your warning."
Yeah. Yeah. It's a tough ride for sure. It's a tough ride for sure. Um, and so with the work that you have done, right? Do you foresee this looking different, right? Knowing what you know about how people end up where they end up, and why, people tend to struggle with substances. We have a new wave of, administration coming in and all of these things. Are there any I guess, pending things that are going to impact the way that this looks for us in the future?
I think that it is not going to be headed in the right direction.
Yeah.
I feel like a lot of necessary resources aren't going to make it, especially not into underserved communities. Um, I remember there was something that was being developed in, I think in Philly. It was like safe houses. So
Mm.
basically, like, okay, people are going to use, right? But also, it would be helpful if you have medical professionals on site. So you make sure that you're giving them clean needles,
Mm.
right? They're having clean supplies.
Yeah.
Because also, when people are using these dirty needles and things like that, that's how their physical health, their medical health, they, open themselves up to all these other diseases. And then, you got people walking around with like open scars and open wounds. They don't want to go and get the treatment that they need because they use those open wounds to shoot in there. It just all of the things, right? It's a domino effect. And I remember reading about it on the New York Times in Philly. The community was so opposed to the safe house. Not, I think because primarily it was the stigma of the
Mm.
substance use, right? But they're not realizing how you're actually saving someone who is struggling with addiction by just
Yeah.
creating the safe space.
Yeah. Yeah. Yeah.
I've seen people shoot up and do things right there at the train station. We sitting here 7:30 in the morning waiting to catch the train. You turn around, this person is like shooting up right there. So if
Mm-hmm.
you give them a safe space with clean utensils, yes, it may not be a behavior that you like, right? But it's an illness.
Yeah.
And, if you can just give someone clean supplies to help them and, at least like a barrier to them not having some medical conditions more in addition to the addiction, like I think it would be helpful. I don't think that this administration is going to care about that. This new administration that's coming, I don't think they care.
Yeah.
Um, Especially not for the black and brown folks.
Mm-hmm.
So I don't know. I feel like it's gonna get scary.
Yeah, 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 yeah. I can't imagine. I can't imagine what that does, right? To our abilities to meet people where they are, right? Especially with the stigma, especially not having the funding and not having the ability. Community readiness is also a thing, right? And so essentially what that means is sometimes communities know they have a problem. They know that there's an issue, right? But when we propose changes and we propose, new initiatives or new programs, sometimes the community is not ready for what that new program or what that initiative may be. And it's not
Right.
because they don't want the help, it's just they have a really difficult time with conceptualizing
Right.
how this looks in my area and what this means for me, right?
Mm-hmm.
Like, Americans are very individualistic, right? And I think
Yes.
many minority communities are beginning to adapt that persona and that perspective in order to survive. But we are individualistic. And so, yeah, I know that drugs are a problem. Yeah, I know that substance use addictions or substance addictions and disorders are a problem, right? And I keep using the words interchangeably because we're trying to move away from like substance addictions to like substance disorders, but we could know it's a problem in my community, but I have to have the community readiness to be able to accept the programs and the feedback that are going to address the problem. And sometimes communities just are not ready because they're not
Yeah.
they're not used to change.
Yeah. Yeah. No, I totally agree. Yeah.
Yeah. Do you have any experience with adolescents and adolescent substance use, or do you really just kind of like focus more on like adults and the family dynamics of that?
Yeah. Majority of my experience is working with like adults. Yeah.
Okay. Okay. Okay.
Mm-hmm.
I was gonna say, I don't know if you've seen the Whippets. Have you seen those?
Mm-mm.
Girl.
I've heard about them, but
I
haven't
haven't
seen
seen it in person. I've just seen it on like my ratchet YouTube TV that I watch sometimes.
them.
Um and what brought me to that was thinking about how much do you think the access or too much access to things has impacted substance use disorders and disabilities. So like whippets can be bought on Walmart, right? Like .com, on Amazon,
Mm-hmm.
right? A lot of the harmful drugs that have not been managed by the DEA and the FDA as of yet are just kind of like out and floating. And so, how much do you think access to this stuff and or social media, so people watching other people, has an impact on what we're seeing right now with substance disorders?
Yeah, I definitely think that social media probably plays a huge part
Mm,
for sure. Because, and then on top of that, I think that people are gonna just try to play chemist and whip up some stuff.
yeah.
Okay, let me see what happens if I mix these two things together, and then with certain shows possibly too that also shows like mixing substances and drug usage that might not be the best. Yeah, it's dangerous.
Yeah. And it's so easy to see, and it's in front of you, it's in your face. Like the whippet things for the kids have taken the internet by storm, and it's so sad to watch, right? It's just like to people who don't know, it's like when you have whipped cream and you spray all of the whipped cream out, there's like aerosol or some gas and they're inhaling the gas, right? And this is not controlled right now. It's not a controlled substance. And again, easy access, right? And people watching other people on social media and wanting to do it. And so it's a really difficult thing to control, especially because people are crafty and they come up with new things every couple of years to work around the system, right?
Absolutely.
Yeah, which is insane, which is insane. Um, Before we close out, I wanted to see you mentioned psychoeducation as a level of support, right? I always want to make sure that we leave people with some feedback and some tips and some knowledge. In addition to psychoeducation, could you possibly give people who are family members of individuals who have been diagnosed with substance use disorders, are there other additional tips that you can give them to be a support to their family members that are currently struggling?
Yeah, I would say if the loved one is currently in treatment, if they are like an inpatient, we know that social workers are present during
Mm-hmm.
a hospital stay. Maybe you all can gather for a family meeting to discuss options for outpatient treatment. What does that look like?
Mm-hmm.
Sometimes I know people are still like in denial or like just like resistant to really being involved in like outpatient treatment. Even if they are resistant to doing that, there's so many like family support groups for partners, whatever the relationship is. There's
Mm-hmm.
so many family support groups and like groups that are there to like support you all no matter what the loved one decides they want to do, because at the end
Mm-hmm.
of the day you still, it still affects your family unit, right? And
Mm-hmm.
you all need to figure out how you want to take care of yourself and be able to move forward. So I think that would be very helpful.
Yeah, that's a good piece. That's a good piece. Like connecting with the social workers, connecting with other people to help you maintain your sense of sanity in the process, because it can be a journey for real, right?
Hmm.
Anything that you can offer for people who might be currently struggling with substance use disorders?
I would just strongly encourage to not be ashamed to lean in and ask for support, right? I think that there's a lot of shame around it, and no one is here to do life alone, right?
Mm,
And we all need somebody.
yeah,
So, find the people that you really trust, that really like care about you to the core,
yeah.
and reach out. And you would be surprised a lot of the times how they will show up and support you.
Mm-hmm. 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 I agree. I agree. And, sometimes it can feel like a silent thing and it can feel like you are isolated, right? And so I would kind of like double down on what Dr. Hollaway is saying, which is like opening up, advocating, trying to connect with people, because the journey in silence is always a difficult one, right? And
Yeah.
so making sure that you connect to people is going to be really, really important, right? So Dr. Holloway, I know right now you're dealing with the babies, you're working with babies. Is there any future work for you in the area of like, marriage family therapy and substance use? And are you going to climb back into the space at some point?
Yeah, so there's actually I'm going through a shift right now. So in the end of December I will actually be moving back to Atlanta, Georgia.
Okay.
I will be completing a postdoc fellowship at Morehouse School of Medicine.
I know
So
that's right, girl. I know that's right,
so
girl.
yes, I'm very excited about that. And the research will be focused on maternal health equity. So I'm just like so excited about doing that work.
I love it bad. I love it bad. I'm so excited for you.
Thank
I'm
you.
so excited for you. I can't stress it enough. I know that everybody has their unique journeys. I know that, this space is a hard one, right? Wanting to contribute, wanting to give back so much, but then having the hurdles to kind of go through. So, I think that you are doing it beautifully. You are doing it
Thank
beautifully.
you.
You're welcome.
Thank
So
you.
before we head out, what is something fun that's on your agenda? Something fly that's on your agenda?
So I have been like going to like a lot of museums, checking out a lot of like exhibits that's been around the city,
Yeah.
and like listening to like a lot of like live music, concerts, things like that. I've gone to like a bunch like this past summer. So I went to see Janet Jackson.
Love it.
I saw Usher, Maxwell. So I've been like leaning into like the live music spaces. So
I
yeah.
love that. I love that for you. I really do. Well, I am not going to hold you any longer. I really appreciate our discussion today. I think it's going to be really, really useful. A lot of insight into what this looks like, and a lot of insight into how people can be more supportive of their loved ones and their relatives. And
Yeah.
so I truly appreciate you for coming and
No
having this
problem.
discussion with me.
Yes, of course, of course.
I'll see you soon. Bye bye.